inherited, we do not know. He was totally asymptomatic before. And when we do his aggregation, what is the pattern we see? The control are responding, no response to ADP, no response to collagen, no response to epinephrine, and this response to risdositol. Diagnosis, Glanzmann's thrombocythemia. But 10-year-old guy only symptomatic for 1 year, not a bleeder before that. So when you are confused, again a hematologist will look at the blood film. And what do I see in the blood film? You see eosinophils, look at the platelets. There are different sizes of platelets, different morphology of platelets. There is anisocytosis of platelets, there is anisogranularity of platelets. There are platelets which are almost gray platelets. There are platelets with 1 or 2 granules, there is anisogranularity. So we had to give a diagnosis of acquired platelet dysfunction with eosinophilia, APDE, which was first described in 1975. It resembles, it's a reversible spontaneous hemorrhagic diathesis. Platelets are bizarre shape, varying in size, pale staining and poor granulation, and there is eosinophilia. It used to be called as allergic vascular purpura or non-thrombocytopenic purpura with eosinophilia. Most common bleeding diathesis in children in Thailand right now. And if you look at the symptomatology, they have, most common is basically ecchymosis or easy bruisability, and they have got a lot of other significant symptoms also with them. And you can see the pathophysiology of that is basically the platelet activating factor is released from mast cells because of eosinophilia, and they degranulate and develop storage pool deficiency. It can be seen with helminthic infections. This is the data on helminthic infection, but the person who described first did not identify in helminthic infection, but in Thailand it's mostly associated with helminthic infection. So laboratory findings are basically large, eosinophilia, mild leukocytosis, platelet count is normal, only 3% showed mild thrombocytopenia, and platelet morphology is the one that is pathognomonic, where you can make a diagnosis of platelet dysfunction in your own lab, just looking at the blood film. Pale stained platelets, few granules in the cytoplasm, including gray platelets, reduced or no clumping of platelets. So the amount of abnormal morphology correlates exactly with the severity of clinical bleed. So more the abnormal platelets in morphology, that's a clinical bleed. Bleeding time is prolonged in 60% of the patient, but PFA is abnormal in 90% of them. And platelet factor 3 is abnormal in 50% of these patients. And of course, aggregation response can vary from Glanzmann's type response to release defect. So when you are going to have patients with these type of acquired platelet dysfunction, do you think you should have an aggregometer? So yesterday I put up this slide for the workshop, no aggregometer for platelet function test, watch this space. My next slide is platelet aggregometry without aggregometer. And that's because I have been having this instrument in my lab, last year I took a session in which I showed you that I'm doing a fully automated risdositol cofactor assay using this because it has got a aggregometry cuvette position. So 3 days back, that is on Wednesday, the Sysmex Japan gave me this software where they developed an aggregometer or platelet mode on my coagulometer, and I loaded this test. So all the tests, and you see the sample volume is 140 microliters and the reagent agonist volume is only 20 microliters. And these are the various settings for that, and that's the calculation method. So it gives you absolute values for the aggregation pattern, and this is a reagent display where you can have all these reagent positions, and this is the result display where it will not only give you the agonist, but it will also give you the percentage response. So this is the controls that we run all the time, every day with the patient, with the coagulometer, with collagen, with ADP, and you can see the aggregometer response exactly looks the same. And then you have the arachidonic acid, and we had a patient who had been given aspirin, and you can see that his response is quite good except with arachidonic acid. So what more can you ask? If you ask my laboratory technologists what's the most painful test in the special coagulation lab, it is aggregometry, because they have one dedicated person has to go stand. I do about 10 aggregometries every day, and add agonists to 1, 2, 3. It takes about 3 to 4 hours for them to finish the aggregometry for that day. Now I have got a walk-away automated aggregometry. I can save on personnel, smaller volume of test PRP, and my patients are very happy because when they come for full coagulation workup, tube, 10 tubes are collected from one patient so that we have enough volume to to complete all the tests. And now, smaller volume of reagent, I can really save on cost. And that keeps my people very happy. These guys are very happy now that we've got a walk-away automated aggregometer on a coagulometer, and my head of department, Dr. Joy, is very happy that I'm going to save a lot of money for him. Thank you very much.